if you have bleeding heavy bleeding, I will say, during your surgery, you will use a long needle and do a sutures in the distal aspect of this area just to squeeze the artery. You do several deep sutures, and by squeezing the artery, you stop the bleeding during the surgery. Concerning the palatal canine, the main discussion is about open or closed technique. So just have a look to the literature. Vince Kokish in 2004 proposes a very elegant and interesting surgery. As you see on the photo, you do an anesthesia, open a full thickness flap, eliminated a part of the bone around the crown, and before closing the flap, you do a large hole in the mucosa. And as you see in the photo E, you can observe that spontaneously, let's say in 1 month, sometimes in 6 weeks, you can observe that first the tooth correct totally its axis, and secondly, the eruption goes spontaneously. So it is very easy in the let's say 1 or 2 months after the surgery for the ortho to bond any device and to put the tooth in the dental arch. Now we will have a look to the Cochrane library, and usually when they don't find evidence in the literature, they say that the choice of the surgical techniques is in the hand of the surgeon or the orthodontist. I will say mainly that it is in the hand of the orthodontist. But we will see in the decision surgical tree the different techniques we can use. Just have a look to the photos, and you see that all around the hole, I have done sling sutures, and those sling sutures help also to control a bleeding if it happens during the surgery. So here it is Victoria. She is 9-year-old. As you see, there is 2 upper impacted canine. Upper right is palatal, upper left is buccal. Just have a look to the palatal one, but during the same session, I have exposed the 2 teeth. So this is the photo at the end of the surgery. It's not a plain hole. I open a flap, eliminate a part of the bone around the crown. Don't touch the cementum, don't touch with your burrs the cemento-enamel junction. And before closing the flap, I make a hole in the flap and again sling sutures all around the hole. As you can see, the crown, the tooth is a little deep, a little high. This is 3 weeks after the hole is not closing. What you see, it is maybe some cells, maybe dental plaque, maybe some food debris. But here, waiting, don't be in a hurry, wait. And you can see that the tooth appear in the mouth spontaneously, and also the correction of the main axis of the tooth. So at this time, it is very easy to the ortho to slowly move the tooth in the dental arch. And when the tooth is in the quite definite position, as you can see, sometimes part of the gum are remaining on the buccal aspect of the crown. So just a second surgery, very small, some drops of anesthesia, and a plain gingivectomy just to eliminate a part of the gum on the buccal aspect of the crown, and that will allow the orthodontist to bond the brace, the bracket of its choice. And this is the final results. And as you can see, on the buccal aspect of the 2 impacted teeth, we have a band of keratinized tissue. And this is very important. So as you have seen in the first clinical cases, in some situation, we need to do a plain gingivectomy just to eliminate the part of the gum. I think that there is a huge difference between modeling and remodeling of the bone and between modeling and remodeling of the soft tissue. And this is, I think, one of the explanation of this remaining of gum on the buccal aspect of the crown. Some of my referees asked me to put, during the exposure surgery, temporary anchorage devices. So here it is a case. Of course, the mini screw is inserted during the surgery, not in the first or a second time. And as you can see, in the mind of some ortho, it helps them to tract first, but also to avoid any root or resorption on the neighboring teeth. But if you remind the proposal of Vince Kokish, only eliminated a part of the bone, realizing a hole in the mucosa, and spontaneously, without any traction, the tooth moves, reoriented its main axis, so going out of the area of the roots and avoiding any option of root resorption. So now we go on the buccal aspect, and when you are in front of low labial canine, try to be a perio for some minutes. And you need to localize the mucogingival junction. Here, as you can see, there is a huge amount of keratinized tissue. So we will do a plain gingivectomy, but keep in your mind that you need to have at the end of the surgery a minimum of 2 millimeters of keratinized tissue remaining on the buccal aspect of the crown. Here it is another case with the two canines exposed during the same session. Mainly, we can discuss about bonding any device, because we know that if we eliminated the gum obstacle, the tooth will move spontaneously. Here again, I localize the mucogingival junction. And as you can see, there is a few amount of keratinized tissue. So the horizontal incision will be a little displaced on the palatal aspect of the crest. And after you realize two vertical incisions, you begin first in partial thickness flap. After, when you are on the crown surface, of course, you are in full thickness flap. And again, when you exceed the apical part of the crown, again, you are in partial thickness flap. That allow you to move the flap and to fix it spontaneously in its definite position. So this is apically positioned flap, and it is, I will say, in the everyday use of periodontists. So this is a periodontal surgery to optimize the periodontal condition around these tooth. Again, another situation, same surgery, little displacing the horizontal incision on the palatal aspect of the crest, partial, full, partial thickness, sutures. And as you can see, the main result is the tooth in the correct position and all the compound of the periodontium, and mainly a band of keratinized tissue. This is a young lady, 14-year-old, lingual treatment. the first question she asked me when she arrived in my clinic is, do you think it will be visible? So I answer her that if I'm able to bond any device on the palatal aspect of the crown, it will be invisible. So again, a little displacing of the horizontal incision on the palatal aspect of the crest. As you see, I try to respect the gum around the lateral incisor. Partial thickness, full thickness, again, partial thickness when I am apical to the crown, and plain simple sutures just to stabilize the flap. Sutures are not here to tract the flap. They are here to stabilize. There is no traction on the flap because the direction of the vertical sutures and partial full and partial thickness flap help to position smoothly the flap on the buccal aspect of the crown. So I bond an eyelet, and here quite a few months before the end of the ortho treatment, all the compound of the periodontium are now present and the band of keratinized tissue on the buccal aspect of the crown. In some situations, the crown of the canine is located on the buccal aspect of the root of the lateral incisors. So here again, we will use a surgical technique in the everyday practice of periodontists, that means lateral sliding flap. And as you can see on those drawings, the most important thing is the orientation of the vertical two incision. They are not strictly vertical. As you can see on the upper drawing, the vertical incision are with a mesial inclination, orientation, that will help the flap to smoothly arrive on the buccal aspect of the crown. Again, there will not be any traction of the flap through the sutures. The sutures will help to stabilize the flap in its definite position. So again, the mucogingival junction, we displaced a little the horizontal position of the palatal aspect of the crest to vertical incision, but definitely oriented in a mesial direction. As you can see, I respect the periodontium on the buccal aspect of the lateral, and with the apical and sliding flap, I moved a part of the keratinized tissue. It is a pedicle flap, apically and laterally positioned. So now let's have a look to eye labial canine. It is a young lady, 12-year-old. And as you can see, the upper right canine is a very high position, just under the sinus, not far from the nasal fossa. So the strategy will be through two surgery. The first one, the objective of the first surgery is to bond the device on the tooth, or on the buccal aspect, or on the palatal aspect. It depends mainly on the access. And as you can see in this situation, I bond the device on the palatal aspect. So open a full thickness flap, eliminated if necessary, a certain amount of bone on the buccal aspect of the crown, just to have enough enamel to bond any device without any blood, without any humidity. And the role, I will say the challenge of the orthodontist is to move the tooth behind the soft tissue curtain and to survey the tooth if it has milk on the fire, because the tooth at any moment have to appear in the mucosa. So if the direction of your traction help you to have the tooth appearing in the keratinized tissue in the edentulous crest, wonderful. But in the great majority of those situations, we need a second surgery. And when the tooth is in a lower position, as you can see, I do an apical position flap, moving a band of keratinized tissue to recreate a band of keratinized tissue and the buccal aspect of this crown. And here are the photos that have been realized by the ortho. I haven't never seen again this young patient. And as you can see, we have a band of keratinized tissue on the buccal aspect of the crown. And in the literature, you will find a lot of papers with CBCT confirming that on the buccal aspect of the crown, there is bone. Here is Solène, 13-year-old, 2 upper impacted canine on buccal situation. It's quite similar that the last situation, just under the sinus, not far from the nasal fossa. So again, 2 surgery. The first one, full thickness flap, will be a closed technique. That means that we open a full thickness flap, accede to the crown. If there is some bone on the buccal aspect of the crown, we eliminate it, or with a burr or with a piezo. We bond a device. As you can see, it is our home-made device, metallic button, metallic ligature with hole in it. And we close the flap in its initial location. And again, the ortho have to survey the teeth like milk on fire. And the teeth goes down. And when the ortho is at the limit of the metallic wire, I do a second surgery, an open techniques with an apical sliding flap to create a band of keratinized tissue on the buccal aspect of the crown. So first surgery is a closed techniques to bond the device. Second surgery is an open technique to create the fourth compound of the periodontium, which is lacking during the traction of the teeth. And as you can see, when all the compounds of the periodontium are present, tooth move with the periodontium. I now want to introduce you a specific techniques which has been developed and described by orthodontists. It is the family Chiles, as you see in the title of the papers. It is the father and son, and they have their clinics in a city named Belfort in the northeast of France. And opposing to the great majority of my referees who refuse to even do an anesthesia, those 2 orthodontists try to get out of the box, and they describe a specific techniques. They don't use a usual mini screw. They use micro screw. And as you can see, those micro screws are 2 millimeters of diameter and 5 millimeters length. And they inserted those micro screws not on the alveolar bone, but in the basal bone, as you can see on the skull. It can be in the mantle area, on the external oblique line in the mandible, or in the symphysis of the molar bone, or just under the nasal fossa. And they realize, as you can see, a kind of double loop, and in those double loop, they screw the 2 micro screw. So I just want to
which journal, Dr. DERSOT, which journal is this?
What?
What journal it was been published to?
Oh, it is in a French journal. unfortunately, all the papers at this time are written in French.
No problem. Can you just send me the link later on when we
Yes,
are
of
done
course.
with this, so that I can share
But
it?
if you go to Google and you only insert the name of the ortho, Chiles, CHILLES,
Okay.
you go directly to the website of their clinics, and all the PDF of their papers are available free.
Thank you.
But unfortunately, at this time, it is only in French.
Okay. Was it a titanium screw?
Yes, the same screw used by maxillofacial surgeon when they stabilize the two pieces of bone.
Plates.
Only the micro screws.
Thank you. Thank you, sir.
Yes, so here is Colombe, 18-year-old. And as you can see, the upper left canine is impacted, eye position and buccal position also. So during the same session, the ortho gave me the device. I am a perio and I'm not really able to bend any wire. So he prepared me the wire. So anesthesia, very small incision, just to accede to the part of the molar bone, and I screw the two micro screw through the 8 loop, and you can see that the wire is in a passive situation. Of course, during the same surgery, I bond the device on the buccal aspect of the upper left canine. And here, you can see now that the wire is in an active position. At this time, there is no braces, no brackets on the teeth, nothing else than 2 micro screws, a bonding device on the canine, and this wire prepared by my ortho referee. Now it is active, and it is the role, it is the challenge of the ortho to move the tooth. When the tooth is in an enough low position, I do a second surgery just to expose the part of the tooth and create again a band of keratinized tissue. As you can see, now there is a lingual orthodontic treatment. And now it is very easy for the ortho to put the tooth in the correct position and to untwist, because as you can see, there is a rotation in the main axis of the tooth. And here is the photo for at the end of the ortho treatment. And again, a band of keratinized tissue on the buccal aspect of the crown. So I want to propose you a surgical decision trees, which is a kind of resume, a kind of abstract of all the clinical cases I have present you. And after I will speak about other teeth. So of course you need to precisely determine the position of the tooth, or mainly the position of the crown of the tooth. If the tooth is in a palatal location, and you choose a closed technique, you do a first surgery, open a palatal flap, eliminated a part of the bone around the crown, and bonding a device. But before closing the flap, you go through the flap with a metallic wire and you close the flap. If we choose the closed technique, in some situations, the crown, the tooth, sorry, has some difficulty to go through the mucosa. There is a kind of rebond. You see a bump, and the ortho called me and he tell me I tracked, but the tooth don't go through the mucosa. So you have to do a second surgery, a hole, and operculization to help the tooth to go through the mucosa. And when the tooth is in the bone corridor, in the periodontal corridor, as you have seen sometimes, you have a remaining gum on the buccal aspect of the crown, and you do a third surgery, which is a gingivectomy. If you choose for a palatal canine the open techniques, you can understand that you will have less surgery. You open a flap, eliminated the bone, bond the device, and before closing the flap, you made a hole in the mucosa, and you close the flap. And as you have seen, or you can bond, but in some situation it's not compulsory, and you have seen that spontaneously the canine move in main axis and continue its eruption, and in a second time it's more easy for the ortho to bond the device. And when the tooth is not far from the final location, sometimes again you have to eliminate a part of the remaining gum on the buccal aspect of the crown. Now if the canine is in a buccal location and a low position, don't forget that even if you are an ortho, you are a dentist, and you are also a perio, and it is periodontal tissue that help you to move teeth. So evaluate the amount of keratinized tissue. If you have enough amount of keratinized tissue, and after your gingivectomy, you have 2 millimeters of remaining keratinized tissue, you do a plain gingivectomy. If you have not enough keratinized tissue, so you move the horizontal incision on the palatal aspect of the crest, and you realize or an apically positioned flap or a laterally positioned flap. And when the canine is in the very high position, the strategy is to do 2 surgeries. The first one is a closed technique. Open a flap, eliminated bone, bonding the device, closing the flap. The ortho tract the tooth behind the soft tissue curtain. And at any time, the tooth have to appear in the mucosa. And in the great majority, there is a second surgery to expose the crown and create a band of keratinized tissue apical to the crown. So now let's have a look to mandibular canine. And this guy or lady, I don't know, will give his name for the eternity to the Mu Parapu classification. It is an X-ray classification only. And as you can see, concerning type 1 and type 2, you have 64% of localization. I never seen during my practice location 5, 3, and 4. So when the canine are in a higher position, the thinking is the same in comparison with the upper canine. If you have enough keratinized tissue, you do plain gingivectomy. So in this clinical case, there is 3 impacted canine, the upper right one, and we do an apically positioned flap, and the 2 lower one, and we do a plain gingivectomy. And we don't bond any devices, and spontaneously, if there is enough place, enough room, the tooth will move in a coronal direction, and it will be easy in a second time for the ortho to bond the device of its choice. So now it is a young lady, 30-year-old and 6 months. Usually I have seen, I have written, and I have heard that when the crown gets through the middle line, it's impossible to move the tooth in its correct position. So with Eric Serfati, as you see, it is the name of my referees, we'll try. So during the surgery, I do laterally sliding pedicle flap. That means that if you decide to do this kind of surgery, think mainly of the main axis of the vertical direction, of the vertical incision. Those two incisions need to be strictly oriented in a mesial direction. That means in the direction you want the flap to move, okay? So I began in partial thickness flap, mainly in partial thickness flap in this situation, eliminated the part of the mucosa on the buccal aspect of the crown, stabilizing the flap with sutures or sutures in the periosteum or sutures on the mesial incision, and I bond the device. And again, I remember, maybe the youngest ignore this guy, Jean-Marc Retrouvé, I think you know him. Alain Fontenelle was the famous orthodontist. I had the opportunity to lecture with him and also to work in my clinics with patients from his clinics. And he regularly said that tooth moves with the periodontium when all the compounds of the periodontium are present. So by moving my pedicle flap and recreated a band of keratinized tissue, the tooth will move with periodontium. And as you can see, it moves. And it moves with the band of keratinized tissue I have created by the sliding flap. And here is the photo at the end of the ortho treatment. I proposed to my referees just to eliminate this. It's not a frenum because there was no frenum in the initial situation. It is a scar, just the result of my distal incision. So concerning mandibular premolar, the strategy is always the same. Here we move a very small apically positioned flap. We move the keratinized tissue located on the occlusal aspect of this premolar, just on the buccal aspect, and we bond an eyelet. Here it is a little deeper. So again, full thickness flap, we eliminated a certain amount of a bone on the buccal aspect. We bond an eyelet, an elastic, and we just position the flap in a small little apical situation. And again, the same situation, again, the same strategy, open the flap, bonding the device. I don't close the flap. I leave a certain part opened, and that allow the tooth to move in a coronal direction. Again, I regularly heard that when the apex of a tooth is in contact with the basal bone in the mandible, it's totally impossible to move the tooth. So let's try again. Of course, the first step is to open a space before moving, trying to move the tooth. And as you can see on the CBCT, it was a little triggering because the tooth was in a lingual position and very low position. So I succeeded to bond a device, but it was a little complicated because of the mouth, because of the tongue, and the lingual position also, the access was a little complicated. And now it moves. Of course, it takes time. And as you can see, there is also a secondary effect on the adjacent teeth, but it moves. At this time, the treatment is not finished, but I think that the great part of the travel has been done, and now it is in the hand of the ortho to finalize the position of the tooth. So Colin, 11-year-old, it is a second lower molar, deeply impacted. And there is also on the distal aspect, as you can see, a cyst. So during the same surgery, I will bond a traction device. I will eliminate the cyst, and the cyst is systematically sent to anatomopathological exam. And it was quite nothing, something very plain. As you can see on the CBCT and the 3D wonderful reconstruction the radiologists have done, it seemed that the mental nerve goes, the mandibular nerve, sorry, goes in between the two roots of the second lower molar. So again, the strategy will be or one or two surgery. So the first one is to accede to the buccal aspect of the crown and to bond the device. Full thickness flap, eliminated if it is compulsory a certain amount of bone, avoiding to touch the cemento-enamel junction. It's not compulsory to expose the entire part of the buccal part of the crown, only a certain amount of enamel to be able to bond. And again, a metallic wire, which is linked to the band around the first molar. The cyst is eliminated. I close the flap, but not totally. I open a little hole just in front of the bone defect. This technique is called marsupialization, and it's allow the filling of the defect by bone coming from the bottom of the defect. And slowly, tooth moves. And at a certain time of the treatment, the patient came again to my clinic, and I do a second surgery, open technique, just to move a band of keratinized tissue initially located on the occlusal aspect of the crown, move it to the buccal aspect to recreate a band of keratinized tissue. So as you can see on these photos sent by the ortho at the end of the treatment, here you can see that all the compound of the periodontium have been recreated. We have periodontal ligament, and the bone has totally filled the defect associated with the cyst. Colin is coming to my clinic 6 years after, just to extract the wisdom teeth. And as you can see, again, of course, all the compound of the periodontium are present around this second lower molar. In some situation, nature is not helpful. And as you can see, the main axis of those second lower molar are very tilted in a mesial direction. So there is several proposals. I had attended to the one-day lecture of Chris Cheng when he was in Paris 1 or 2 years ago. And I know that he liked a horizontal mini screw inserted in the vertical branch of the mandible. In those situations, I bond a metallic button, a metallic wire on the two teeth. On the right side, it goes very fastly. On the left side, it takes more time. But at the end of the treatment, all the compound, and mainly the bone, are present around the two lower second mandible. Here I tried the proposal of the ortho Chiles with the two micro screws. So again, those two micro screws are 5 millimeter length, 2 millimeter diameter. I bond on the distal part of the second lower molar an eyelet. I try, even if I am not an ortho, to bond a wire, and with an elastic, I activate the movement of the second lower molar. The main direction is in apical, is in coronal and distal movement. Now have a look to the central incisor. There is an endotoma. I prefer to do during the surgery, extraction of the odontoma and bonding a device. Just try to be at the place of the patient, not to be always as a dentist, but try to be at the place of the patient. I think that patient prefers to have only one surgery, if possible, of course. So I prefer to extract the odontoma and to bond the device on the central incisors. But I know that some of my referees tell me first to extract the odontoma and second to, in a second surgery, some months after, to bond a device on the incisors. I definitely think that in this clinical case, due to the main axis of the crown, I don't think that the crown will move and correct its position to go in the good location. So again, tooth move with periodontium. There is, as you can see, a huge discrepancy between the clinical crown height of the left central incisors and with the right central incisors. It is not a gum recession because the cemento-enamel junction is not appearing, because the surface of the root is not appearing. What you see on the left side is the anatomical crown. What you see on the right side is the clinical crown. But wait, don't be afraid, wait, because time, maturation, and growing help us. And as you can see, 1 year after the end of the ortho treatment, there is quite no discrepancies. And if there is a high demand of the patient or a high demand of the parent of the patient, it's not very difficult to realize a very small gingivectomy if there is enough keratinized tissue on the buccal aspect of the crown, here on the right side, just to have the gum level at the same position. Second upper molar, so always the same strategy. If we can expose it, only one surgery. So we exposed on the both sides, and it helped the ortho to put the two second upper molar in the good position. Now I want to show you several situations about what not to do. So the first clinical case, it is a young man, 13-year-old, and the parents of the patient moves. They were living in the suburb of Paris, and they move in Paris. So they change the orthodontist. And the orthodontist sent me these photos. The main mistake is to have chosen an open technique. As you can see, it is a upper buccal eye canine location. So if you are okay with my surgical proposal, surgical trees, the first surgery has been a full thickness flap, bonding a device, close the flap in its initial position, tracks the flap behind the soft tissue curtain, and when the tooth is in an enough low position, an apical position flap just to move a band of keratinized tissue. So I have to deal with this situation and to recreate a band of keratinized tissue. So I eliminated all those soft tissue reaction associated with inflammation. Inflammation is due to the brackets which has been bonded on the crown, but also it's quite impossible to brush so high in the buccal position. So there is dental plaque also. So I eliminated all those soft tissue reaction, and I have to recreate a band of keratinized tissue. So I have to do a free gingival graft. And usually the sampling of the graft is on the palatal side, but just have a look to the crest and you see that there is a huge amount of keratinized tissue. So I take the graft not on the palatal aspect, but on the crest. And the main challenge was to suture this free gingival graft, but because in very high location, it's quite very difficult. And it's also very difficult to realize sutures on the periostome. And again, I have recreated the fourth element, the fourth compound of periodontium, so the tooth will move with the periodontium. And as you can see, there is a band of keratinized tissue. I asked for my referees for the final photos, but she was a little ashamed and she told me the plaque control of this patient was so awful that I don't want to send you the photo because I am not so proud about the result. Again, what you should not do. Maybe the exposure surgery have been done with laser or with blade. I don't know exactly. Again, the parent of this patient moves from an area of Paris to another one, so they change the ortho. When you have a look to the X-ray on the right side, the canine is in a, let's say, medium position. On the left side, it is in a high position. So during the same surgery, I would extract the two baby teeth. Maybe on the right side, a gingivectomy if the crown is in an enough low position, or an apically positioned flap if it is if I'm not able to do a plain gingivectomy. On the left side, I will have done two stages. So first one, close technique, open a flap, bond the device, close the flap, and a few months after, apically positioned flap. So I told to my referees, I am not able to reclose the two wounds. So tract the teeth and we will see. But you will have the exact illustration of tooth moving with periodontium and tooth moving through periodontium. At this time, the treatment is not finished, but just have a look to the two canines. You can see that there is quite no keratinized tissue on the buccal aspect of those two teeth. We are directly in the mucosa. The mucosa is very thin, and it seems that you see directly the root. Maybe there is a very thin layer of bone on the buccal aspect of the crown, of the roots. Maybe, I don't know. But those two teeth are of high risk of gum recession in the futures. Because if there is a lack of bone, it is one of the explanations of gum recession. So as I told you, this is the plain illustration of moving teeth through periodontium. The bone don't goes with the tooth. Tracked in the wrong direction. I don't have realized the first surgery. But my referee, who usually send me those kind of teeth, give me a phone call and ask me to help her because as you can see, the crown appear not in the keratinized tissue, but in the mucosa. So I have to realize an apically sliding. You will see that is sliding like a Z, like a Z. Here it is a surgery. I move in a pedicle flap, the keratinized tissue, which was located on the occlusal aspect of the crown, partial thickness flap, full thickness flap, and again, partial thickness flap to be able to suture it in a most apical position. So I have created a band of keratinized tissue, and those photos have been realized by the ortho. I had never seen again the patient. And here is the final photos. And as you can see on the left side, there is again a band of keratinized tissue. So all the compound of the periodontium are now present. Neglect the second surgery when the tooth is in a high position, as I told you. First surgery, open a flap, bonding a device, you close the flap, you tract the tooth behind the soft tissue curtain. And at any moment, the tooth have to appear in the mucosa. And systematically, in the letter I sent to my referee, it is written the same words. If it is appear in the mucosa, before it appear, I will realize a second surgery. But some referees don't read the letter or forget what I have written in my letters. And as you can see, there is a total lack of keratinized tissue on the buccal aspect of this canine. It is mucosa. So we need to do a second surgery, and the second surgery will be a free gingival graft. That means two wound on the palatal aspect, on the buccal aspect. Same for this central. Here you can see quite no keratinized tissue. Physiologically, there is few, let's say, ½ millimeter of keratinized tissue, because in the keratinized tissue you have hemidesmosome, and those hemidesmosome are in close contact with the hard tissue of the teeth, and those hemidesmosome are closing the inner part of our body and the outer part of our body, or if there is quite no closing, let's say when our first tooth appear in our mouth, we will be dead because all the bacteria in our mouth will go inside our body. And the same for a lower impacted canine. No keratinized tissue. That means that it is compulsory to totally modify the periodontal environment and to create a band of keratinized tissue through a free gingival graft. Laser and impacted tooth. I never use a laser in my practice, but I totally agree that in this kind of surgery, it can be helpful. But in this review, it is a French one, and it is considered to be a very high-level review, clinical review. Those two photos were in an article, and it is definitely a mistake, because with the laser, they have totally eliminated the band of keratinized tissue. We are directly in contact with mucosa. It has been so easy, even with the laser, to eliminate a part of the keratinized tissue just at the point of the crown, just few millimeters, and leaving the 2 millimeters just adjacent to the mucogingival junction. Two heavy forces when you tract. It is a central incisor. It is in a low position, so only one surgery, apical position flap, exposing a part of the crown, bonding a device. So something I will say a kind of routine surgery. And again, I received a phone call some months after, and my referee tell me, I don't understand why, but there is always a reddish area on the buccal aspect of the crown. And I think that the patient have a relative good, average good plaque control. So I asked him to send me photos, and you see the photos. And this is not inflammation due to dental plaque. This is the inner part of the sulcus, the inner soft tissue part of the sulcus. And it is reddish because of the discrepancies between the compound of the cells. So I ask my referees, ask your patient to brush, stop to track the tooth, ask your patient to brush, and you will see that in few weeks, it will be again pink. The difference is only due to the histological difference of the cells. So my first conclusion concerning the 595 canine that are still on the arch and with the ortho treatment definitely finished. Only 13 teeth don't move. That means 584 teeth are in the arch with all the compound of the periodontium. And I had only 5 debonding. I just want to write this sentence because debonding can be a problem if it is during the traction after a closed surgical techniques. That means that you have again to do a second surgery, anesthesia, incision, elevating a flap to rebond. If debonding appear during the traction with an open surgical techniques, of course, it is very easy for the ortho to rebond any device. So my gimmicks, I will say, concerning impacted teeth, except of course the teeth that are ankylosed, when you have or on your panoramic or on the CBCT images that confirm that there is a close contact and bone is in the root, of course, you cannot move those teeth. Or when teeth where it will be totally impossible to move the tooth in the correct position because there is so much obstacle between the tooth and the definite location, you don't move those tooth, but give teeth a chance when I will say there is a plain, a normal location without any specific images on the X-ray. And when the tooth don't move, because as you have seen among more than 400 canine, impacted upper canine, 13 don't move. So when the tooth don't move, what we can do, and I want to propose you a solution, but at this time I have only one cases. So in the pyramid of evidence-based, as you know, it is in a very low position. But as all clinical proposal, it can be interesting in some situation. Maybe some of you have heard about a proposal from a French team from the Dental University of Montpellier. It is a city in the south of France. And the writers, the teams are mixed of orthodontic department and periodontic department. And they have written 2 papers. The first one is in French and the second one is in English. And the techniques they have developed, they called it orthodontic bone stretching. They are able to move ankylosed teeth. I repeat, to move ankylosed teeth. As you know, usually when children go fall downs and there is an impact on the upper incisors, ankylose can happen some months or some years after. And there is usually, when the children goes for orthodontics, vertical discrepancies between the level of the other incisors which are able to move and the impacted one. So they open a flap And with a piezo, they do a bone defect 1 millimeter large and 5 millimeters deep on the mesial aspect, on the distal aspect, and on the apical aspect of the impacted tooth. And immediately after the surgery, they tracked, not with orthodontic forces, but with orthopedic forces, more than 150 grams, sometimes 200 grams, and they are able to move the impacted teeth. Of course, the movement is not due to the periodontal ligament. The movement is due to the capability of the bone to stretch. They hurt the bone, so they optimize modeling, remodeling of the bone are there, and they are able to stretch the bone. If you are more interested about this proposal, I go to Google and insert orthodontic bone stretching, and you will see that the main authors, Dr. Bousquet, the first name you can see on the slide, he is giving a lecture in English. I think it was during one of the congress of the EFP, the European Federation, Periodontal Federation. And this video is in English. So I have read those two papers. I have 3 or 4 cases concerning impacted teeth, but I was confronted to Dilara. Dilara, she is 14-year-old, and she came to my clinic referees by Dr. Emre, one of my referrals. And I will say again, it is a kind of routine. So these tooth is in a medium position, not really high, but not really low. So I decided to do a closed surgical techniques, open a flap, eliminated a part of the bone, bonding a device, and close the flap to its initial position. And the tooth moves. 3-4 months after, I receive a phone call from my referees, and he tell me the tooth stopped to move. I don't know why. I've tried to tract a little heavily, but it don't move. So after reading the 2 papers about the orthodontic bone stretching, I tell to my referees, I will try something. I don't know if it will succeed, but let's try. So you can see that the tooth really had moved. There is a huge difference between the first photo during the first surgery and the second one. And you can see that there is 2 bone wounds that have been realized with piezo, one on the mesial aspect, one on the distal one. I avoid to touch the bone on the buccal aspect of the lateral incisors. And I don't do the horizontal bone wound because I was afraid to touch all the root of the apex or to interrupt the blood supply of the tooth. Hopefully, tooth moves. And as you can see at the end of the ortho treatment, there is again a band of keratinized tissue. Again, you can see that there is discrepancies between the clinical crown heights between the right canine and the left canine. And again, don't be in a hurry to take a blade and to eliminate a part of the gum. Wait for growing, wait for maturation, because as you know, with maturation, all the clinical crown will lengthen a little. So it is compulsory to wait. Again, if there is a high aesthetic demand, of course, you can eliminate some part of the keratinized tissue on the buccal aspect of the upper right canine, but don't forget to locate before the mucogingival junction and to add at the end of your surgery a minimum amount of 2 millimeters of keratinized tissue. If you want to read more about the topic of impacted teeth, you have several books. The first one is written by two French practitioners, and it had been translated in English. It is in Quintessence edition. The second one is written by Adrian Becker. Adrian Becker was at the head of the orthodontic department of the dental university of the hospital of Hadassah at Jerusalem in Israel. He recently, maybe 2 or 3 years ago, retired, but he has written these huge books. And even if he is an orthodontist, there is a lot of chapters about surgical techniques. He had also a website, and regularly, but since several months he stopped, but regularly he inserted in his website different clinical cases about impacted teeth. I have shown you the specific techniques developed by French orthodontists with micro screws. So you can go directly to the website of those orthodontists, or you go to Google and you insert Chiles orthodontist. You will accede to the website of their clinical, and there is all their papers in French, unfortunately, available for free. But I can announce you that I have proposed 2 months ago to Quintessence France to write books about the topics of impacted teeth, and I have asked Dr. Chiles, father and son, to write a chapter specifically about what they have developed. I have written also papers, some in French, and the papers on the right side, you can see, is in a journal written in English and in French, International Orthodontics, and so it is very easy to read this paper for English people or English-speaking people. And you will see again all the great majority of the cases I have shown during my webinar. Sorry, it is my last slide. I hope that there is a lot of questions. Don't hesitate. I am here for you.
Yes, there are a lot of questions. And many of the questions.
That we have maybe some minutes to answer to all the questions. And if I can also accede to the question, yes.
Okay. Thank you so much for such a lovely presentation, Dr. Jean-Marc DERSOT. And it personally, cleared a lot of my doubts which I had while treating the cases with the impacted canine or premolars. So let's go to question answer section. Okay. The first question is
I don't
about.
see the question, so if you can read the question.
Yeah. Please tell about the Quintero sign.
When the canine is located on the buccal aspect of the lateral incisors, usually the root is pushed in a palatal position, so the crown is pushed in a buccal position. So it can be, not systematically, of course, but it can be a compulsory sign, not a compulsory, sorry, a pathognomonic sign of impaction of the upper canine on the buccal aspect of the lateral incisors. Quintero sign.
Okay. Then how did you suture flap in your patient Solin? I think you took a micro sutures little later so that it.
I regularly used absorbable sutures.
Okay.
First, because I have some patients to come to my clinic, it's take 1 hour and a half. So I don't propose to the patient to come to eliminate the stitches during a second consultation. So in the great majority, I use absorbable sutures. The sutures are realized or on the periodont or on the periosteum, if it is possible, or on the limit of my vertical incision.
Okay. The question is about deadening control of lower impacted premolar to bond a button.
I have shown you
yes,
different location, even the one which was very deep. It's bonding is the same on all teeth, but the main condition is to avoid any humidity, so no bleeding, no saliva. So the help of the dental chair assistant is very important.
yes.
I will say that I do this surgery with 4 hands, not only with mine, but I need the help of the dental chair assistant to push on the lip and also to push on the flap when we are on the palatal aspect, and also to suction. But I always say, even if I'm not an orthodontist, I always say that it's quite not difficult to bond anything on the tooth, because all the GPs are able to do a composite.
True.
But the main rules is to respect the time of the different steps of bonding. That means the times with phosphoric acid, the times to rinse, and the times with the light to polymerase the bonding materials. If you respect all those times, you will have debonding or not at all. As you have seen, I had 5 debonding, but you will lower dramatically the number of debonding.
Yes.
Concerning impacted teeth, I know that when you, orthodontist, bond, sometimes your patient don't follow the rule. They eat
hard stuff,
chewing gum, they eat something too hard, and so and so. It is in your world, it's not in my world. But you are in front of all those problems every day.
There's another question from Lee Han Chang. Apically positioned flap will be carried out when the canine crown is at the non-keratinized tissue. Question.
Can you repeat it?
Yeah,
sorry.
because I'm an orthodontist. Sometimes it's periodontal questions. I'll just repeat it. Apically positioned flap will be carried out when the crown, canine crown, is at the non-keratinized tissue.
You have always keratinized tissue around. In the question, it's not precise if it is upper or lower.
Okay. No. Okay. Let's go to next question.
Let's go upper. If you have impacted palatal canine, there is no problem of keratinized tissue.
Okay.
But on the palatal side, you have a large amount of keratinized tissue. The main problem is when you have buccal impacted crown, buccal impacted canine. So as I have described in my surgical decision tree, it depends on the level of the tooth, mainly. But you will have always keratinized tissue, because you will be always able to displace the horizontal incision on the palatal aspect of the crest before elevating the flap and moving the band of keratinized tissue. So the lack during the surgery I had described, I never had problem of lack of keratinized tissue. The lack can depend when the tooth appear in the mucosa.
Okay. The next question is how to choose between open and closed technique for palatal canine impaction. Do you always have a second surgery or the closed technique on a palatal canine impaction?
I try every time to do an open technique. to avoid any second surgery, just to do the operculization, to do the hole in the mucosa. So if I'm able to, I prefer to do an open techniques.
Okay.
The main problem when you do an open technique is to avoid the wound to close before the tooth will appear.
Okay.
I think that with sliding sutures all around the hole, I avoid any closure. I know that some practitioners put, for example, a periodontal pack, but I don't know how to stabilize the periodontal pack. It will fall down, yes, maybe a few hours after my surgery, or I can do, I will say, sutures all over the periodontal pack. And secondly, when you take out a pack, you have so much dental plaque, it stinks usually. So I prefer to leave my hole without anything in it.
What is your take on barricade?
I recently read a paper where they propose to avoid any closure of the wound for the canine in a palatal position, to bond to the crown a ionomer. And when the tooth move, to eliminate regularly those ionomer.
Okay.
But I have no experience about this proposal.
Okay. On which day post-surgery you advise a suture removal? But as you said, you always use absorbable.
I try to avoid, I use, I will say in 99% I use absorbable sutures.
Okay, there's a question. So can you please tell which approach did you choose to expose the lingually impacted second premolar?
In the case I have shown?
Yes.
It was a little delicate, of course, but on one of my photos, I present, I try to escape, no, it's not possible. In one of my slides, I show 3 proposals of bonding device. And I say that I use the upper one, which is in-home made, a metallic button and a ligature, a metallic wire for ligature with hole in it. So with this kind of device, which is really rigid, I am able to take the device not at the bottom. I am able to take the device at the end of the metallic wire that allow me to bond very deep teeth. And I have only to push when I put the composite, I have only to push with a sure or any instrument and to rapidly bond with the light. But with my device, I can take this device at the end of the metallic wire and not on the metallic button. I think that you understand what I am describing.
Yes.
The 2 other proposals, okay. The lower one, it was with a golden chain. It's impossible to take it is impossible to take at the end of the golden chain because it always falls down. But when you have to bond an upper canine on a palatal aspect, you have to bond in an upper direction. The other proposal was an eyelet with a metallic wire, and the eyelet systematically goes down. So those 2 devices, which are proposed by Orthodontics company, they are totally inadapted for bonding in some specific area.
Okay, I'll take last question. What is a pedicle flap, and when you prefer it with impacted canine? Pedicle flap. Pedicle flap.
Yes. It is a technique which has been described for a long time in periodontics, in periodontology, and it has been mainly used to cover root surface. It is one of the techniques described to cover root surface when you have gum recession. And I have plainly applied this technique for exposed of the crown.
Okay. There are certain questions, but we will not be able to take all the questions because it will be outside of the scope of this. I would request Dr. Jean-Marc DERSOT and other panelists to please put on the word here, and if they have something to share as well.
Yes, thank you, Jean-Marc. Great lecture. I'm not going to be a good periodontist, that's for sure. Forget it. But I'm happy you get people like you to help me out. It's fantastic. So what I want to say is, I was looking at, there were two questions mainly. I don't want to take the whole time. One, you did an exposure on a very young kid of like 9 years old. And Kuro describes that you could probably extract the primary tooth and wait a bit longer. So that was my first question. And the second one, you showed a lot of heavy forces, and sometimes the coverage of the root was not as good as it should have been, especially on canines. And I was wondering if you, I mean, again, I put you on the spot here, maybe the mechanics used by the orthodontist was more of a straight wire approach with a lot of forces and misdirected forces that end up actually making your life more difficult. But I don't want to put you on the spot, so I don't know if you can answer that one.
Concerning your second question, I'm not able to answer, of course, because I will say that I am only an actor of the ortho treatment. I receive the patient, do a specific act, specific surgery to head the ortho. I am not the guy who decided which direction, which kind of traction devices they will use after my surgery.
The